Good morning, everyone, and thank you for joining us today. Malnutrition continues to be one of the biggest challenges that India currently faces, especially for women, children, and the underserved communities. And despite years of efforts, gaps in awareness, access, and accountability still persists, especially at the last mile. In an effort to address this and share some thoughts and learnings, Piramal Foundation has collaborated with Avian WE to bring together diverse voices of experts to explore how digital innovation and its intersections with nutrition can help strengthen nutrition delivery system. To take the proceedings forward, I will now invite Mr. Pallav Patankar, who's the Vice President Digital Bharat Collaborative, which is a part of Piramal Foundation. Pallav also leads the Digital Public Health Center of Excellence. Over to you, Pallav.
Thank you, Sharmishta, and a warm welcome to Dr. Madan Gopal and Dr. Sujeet Ranjan from the Piramal Foundation. On behalf of the team, I welcome you to this forum. Uh, I would first like to introduce the two of them to the audience today in terms of their amazing work which they have done for over 3 decades. So Dr. K. Madan Gopal is a public health administrator at the National Health Systems Resource Center, the NHSRC, under the Ministry of Health and Family Welfare, MoHFW, Government of India. He has over 3 decades of experience in health systems, strengthening policy, planning, and implementation. And prior to this current role, he served as a senior consultant in health senior consultant health at Niti Aayog, where he played a key role in shaping the national health and nutrition policies. And his work continues to focus on advancing primary healthcare, improving health governance, and promoting evidence-based reforms to strengthen India's public health systems. Welcome once again, Dr. Gopal. It will be a pleasure speaking to you in terms of our nutrition discussion. Uh, Dr. Sujeet Ranjan is the Chief Executive Officer at the United Way. He's our second speaker today. A seasoned public health and nutrition expert, he has been at the forefront of advancing large scale nutrition programs and multi sectoral collaborations for close to 3 decades. Dr. Ranjan has played a pivotal role in shaping strategies that bridge policy, implementation, and community engagement to address malnutrition and improve maternal and child health outcomes across India. His leadership continues to drive impactful initiatives aimed at building a well nourished and a healthier nation. Dr. Sujit Ranjan, welcome once again. Has he joined us? Mr. I don't see him.
Yeah, thank you very much, Mr.
Yeah.
Pallav. I'm very much
Yes,
here.
we have.
Thank you.
Okay. Thank you. Welcome, Doctor. So, to just for the audience, benefit of the audience, we have one individual, Dr. Sujit Ranjan. I'm also happy to note that he used to be with the Swasthya group at one point in time. So,
Yeah.
you know the work that we do, and you also understand. He represents the development sector, the civil society, which is very much on the ground working out there. And Dr. Gopal also represents our collaborators, our partners, the government in terms of how do we take these policies and implementations forward and keep them sustainable within the government's program. So welcome both, and I'd just like to bring the attention to why we're doing this webinar. As you would be aware, there was the Poshan Ma, which was from 16th September, I think 16th September to 17th October, and we did want to do it during that period of time, but were unable to do it within that specific slot thanks to many things. So better late than never. The idea was to discuss about these various aspects. With these individuals. So yes. Uh, so yeah. Uh, uh, Thank you. Oh, right. Just a second. So the other thing which I would like to point out in going forward is today we are in that space of within the country, within India. we have gone post the situations of, let's say, malnutrition deficiencies such as a kwashiorkor or a marasmus. The situation today goes more into probably nutrient deficiencies at a very low level, such as probably an iodine deficiency, something extensively that Dr. Pandav had worked on. Unfortunately, he could not join us today. You also have folic acid, or you have iodine, or you have zinc. You have all these kind of micronutrients which are not really going into a child's journey. So if we were to really talk about a Vikasit Bharat in this country, and we're talking about 2047, we're talking about a $30 trillion economy, the potential, the need for having nutrition for a child and the successive growth becomes extremely essential for the development of this country. So Viksit Bharat has to come along with all these specific requirements, from a viewpoint of nutrition. Uh, we have seen that, and as Piramal Foundation, what we have observed is that we have observed that there is a concept called multidimensional poverty, and if you were to go into smaller areas, locations, or areas, we see that this multidimensional poverty, be it due to access to education or be it access to health, accentuates the problem of nutrition. So what typically will happen is, though we see 1 in 5 children which are stunted or 57% women are anemic, in some places this might go much more high. And we as an organization are trying to see within the whole folds of Digital Bharat, how can the current programs on the ground, something that Dr. Sujeet Ranjan does or Dr. Gopal do, how can those particular points be improved? Can we use technology to improve that? And that's where the whole concept of Digital Bharat will. So I'd like to stop there just so that we understand where do we come from as an organization or as a capability within Piramal Foundation as Digital Bharat Collaborative, and probably go to Dr. Sujeet Ranjan as as an example, and I'll come to you, Dr. Gopal, after posing him a question. Is Dr. Sujeet, you have also seen, from a civil society perspective, you have seen a particular journey which has happened within India. Uh, if I were to ask you, what has been your observation in terms of the programs which have been on the ground in the last 10 to 20 years, and then I'm also asking you, have you seen any use of technology or have you seen any successes out there, and if you can think of any programs which we have run on the ground as a country, from a civil society perspective, for a nutrition benefit. So I would just like you to reflect on that and and tell us if there is something that you would like to add.
Sure. So first of all, thank you very much, Mr. Pallav, for having me here today. And this is a very important discussion. And we know this fact very well that nutrition has the power to transform and empower the present as well as the future generations. And I'm in this sector for last more than 3 decades. And I have seen like how the nutrition scenario, the even the interventions changed in last more than 2 decades, and how that is very much relevant in this today's Viksit Bharat. So good nutrition is the foundation of a Viksit Bharat, ensuring that every citizen, especially I can say children and women, how they can have access to balanced, safe, and affordable food. That is the key to achieving India's vision of holistic development. And if I see the journey, like I'm for last almost 2 decades, I can say. I remember in the year 2007. I that time I was representing CARE as a director CARE program, and I was managing the program like Jharkhand, Bihar, and in the year 2007, the very significant phase when the NFHS National Family Health Survey 3 results highlighted India's very slow progress on nutrition. And that time, the first Lancet series of on maternal and child nutrition was also launched in the year 2007. So that 2007 is very important for me as well as for many public health nutrition professionals. And that time, we are working under the very close supervision guidance of the Bharat Ratan Professor M.S. Swaminathan. And Professor M.S. Swaminathan, uh, like he decided to go for a multi-stakeholder nutrition conclave, and he laid the foundation for broad stakeholder coalition and coalition for nutrition. And I also got an opportunity to lead that coalition for food and nutrition security later. But in the year 2007, that was started. And the objective was very clear how we can bring all the public health professionals, the program leaders, the policy leaders, the technical experts, national, international experts, how we can bring all of them together under one platform. And so that was started in 2007. And then in the year 2010, 9 and 10, the first leadership agenda for action was released after the series of consultation of 2 to 3 years, and the first leadership agenda was released. And the first time, the focus was on first 1,000 days, essential nutrition actions, and the role of leadership was very much highlighted in that agenda for nation. So by this way, the journey started from the delivery mode, from the charity mode to a very different right-based approach, very focused approach, how we can address the mother and child's nutrition in a more focused manner, and how that will go for a holistic development. So that's the journey started. So again, this journey not just released the this leadership agenda, but again in the year 2013, the Lancet, the second series was, you might be knowing, the second series of Lancet on maternal and child nutrition was launched in the year 2013. And that time, this agenda for leadership was very much relevant to the entire phase. And that the entire focus was not only for the food security, that how we can move to the nutrition security. So that was the journey started. And the six, I still remember the six major agenda. That was the sustained leadership, how we can ensure, how we can ensure the uninterrupted supply of the high quality coverage and the supply, adequate financing, then the address the food security and the healthy diets for all, and then how nutrition as a development indicators. So here the most important, you rightly mentioned about the technology, how the technology can be a kind of helping hand for ensuring the right nutrition, and how we can invest in the data system, the technology, how we can go for the live monitoring the system, how we can, like, there should not be any kind of dilution in the behavior change communication, the right messages from the Anganwadi centers, from our Anganwadi Didis, from the that time the this ASHA workers, the ASHA Didis, then the ANM, how we can use the technology in a better manner, and how technology can be a kind of tool for the functionaries as well as for the monitoring of the program. So I pause here and then we can discuss further. Yeah.
Thank you, Dr. Sujit. Dr. Gopal, are you there? Over to coming to you. So, Doctor, based on what Dr. Sujeet Ranjan mentioned, I just wanted to also understand it from a government policy perspective and a Niti Aayog perspective, since you've been a part of those conversations. Uh, how are we translating some of these learnings on the ground in a policy way, and how do we in the future see technology becoming a part of this conversation? Does it end up being a very essential, process or a resort that we are going to follow? I would love to hear.
Okay, thank you, Pallav, for this opportunity. I think I was listening to all the people, and it means you and Sujit. And one of the important things which we talk about, that how the policy will take a shape. The important thing is that what I see personally, I believe that there's a disconnect between what we think at the policy level and what actually happens at the field level. So we have to see that how to bridge that thing. I think technology could be an enabler for bridging that gap so that the trust and other things. The other thing is trust element which is to be there in the field, that is also to build in. I think I made a small presentation on this. So if it is allowed, I think I have shared the presentation
Yeah,
with
sure.
Preeti. Preeti, can you please share the presentation? It's just that because we have to see that how we bridge the gap. To understand that, you see that whole efforts are made in having a safe mother and safe child, right, through our enhanced RCH program. The mother and child, as a result, what happens? The underweight at the time of delivery is around 10%. You think about the magnitude, appreciate the magnitude of the problem. That means the 90% women they deliver the average weight, baby, the average weight at birth is around 2.5 kgs. We say how much the quality of measurement is there. That's a different thing to be discussed and debated. That's a different thing. But statistics say that 90% of the baby weight is as per the norms. Only 10% underweight is there at the time of birth. But by the time the baby becomes 5 years, this underweight becomes 35 to 40, and at some of the regions it go to
Ah,
50%. So this is an area where a lot of work is to be done, and we have to see that how we can use. I am not talking about the other strategies and other things. We do have policies. We do have Poshan Abhiyaan. We had this ICDS program since since 70s. That means the supplementary nutrition, the calorie announcement, that is already there in the scheme. But the whole thing is there's a disconnect. And we can see that the technology can be an enabler in the nutritional service delivery, because we have to see that how whatever efforts which we are making, that has to be repurposed and see that how we can energize the efforts which we are making. And in which I think I am waiting for the presentation.
yeah.
So,
Preeti, are
Preeti,
we
please
ready
help
with
me.
the presentation?
So we have to see that how we can enable that so that we can drive trust as well as we can have a good collaboration.
Yes.
The examples is that when the Poshan Abhiyan 1.0 was launched, we tried to digitalize things. But we are talking about numbers. If you take the sheer numbers, so there will be some good practices, some bad practices, but nevertheless, it has shown us a way that how the digital adoption can result in the better uptake of services, the yield and other thing. The main problem is that we should have data that is what is the actual magnitude of the problem. There is only we have to wait for surveys. It's very pity that we are having a scheme which is providing supplementary nutrition. We are having our HMI system. We are having this, but we have to wait for surveys which can give a uh, exact quantum of the thing. Next slide, please. So, so can I, if you allow me, I can present it. Otherwise, it is taking more time.
Time, right? Yeah.
Okay, so let me check whether it is open. If it is open, then I will be presenting it from here only. Is it ready or shall I do it?
Preeti?
Yeah, you can present, sir. That
Yes,
will be
so
better.
you may do it. That'll be much.
I was just waiting. I've become a bit lazy because I thought that it would be from that side. Don't worry about it. I'm just making it. So, apart from that, while I'm loading it, one of the other aspects which you need to cover, as I mentioned, that's a as a uh, at the time of birth, there's a deficiency of 10%, 10%. Then when the child becomes 5 years, so the deficit becomes more than it becomes more than 30, 38, 40%. So we see that how we bridge this deficit. This is only possible when there is sharing of information and other things. Okay, so now I would be sharing this presentation
So
with, okay, so it has to be Windows.
share. They will have a share icon on top.
Yes, yes, yeah, I'm sharing it. Is it
Yeah.
visible now?
Yes, it
Yes, it
is.
is.
It is visible. Okay, that's fine.
You
So it has the lower icon. I think you think as yes. It's in slideshow now.
not yet.
Okay, that's fine. So as I mentioned, that the bigger picture is that how we connect with the community. The whole message which is coming, the deficiency which was 10% at the time of birth, the deficiency which become 40% at the time of 5 years. That's why, as Sujit has mentioned about 1,000 first 1,000 years. So how we can connect the communities and the decision makers of reducing this thing? Only technology can do that. We have to see that how the malnutrition, it also gives a message that how the malnutrition can reflect the systemic gaps. There is something is disconnected because the birth is there. We do have a Asha program which is there wherein she gives the post delivery home visits are there. The newborn care is there. HBNC program is there. Newborn care visits are being made. But where is the data? Where is the access? And who is accountable for the deficit? This 38, the 10% becoming 40%. Where is the accountability mechanism of this? And how we can leverage the technology, and it provides an
Dr.
opportunity
Gopal, are
to
you
bridge.
changing the slides because we the slide
It
is
is
not
changing. I am
changing?
changing the slide.
Oh,
It is
okay.
not. I have not changed. I'm the first slide only, the
Oh,
big picture.
okay.
It
Okay.
is still there. So we see that how we can empower people. It's not just an automated process. You see how the digital tabs were used for Poshan Abhiyaan 1.2. See that how immediately the information is translated there. But there also it's just a manual version in a digital way. We have to see that how we can automate it so that it can empower the people in understanding that you see how the small apps and other things which immediately triggers that you are having. You take the example of pulse oximeter or the glucose monitoring and the BP monitoring point of care devices. See that how they have empowered the people in understanding this thing, and similarly we can also empower in this way. If you look at the technology-led innovations which we are having. We have the Poshan Abhiyaan. As you have asked about the policy alignment at the national level, we have the Poshan Abhiyaan for real-time monitoring, so that there is a improved convergence between all the three actors, ASHA, A&M, and the Anganwadi workers. So we are talking about it so that we can do a tracking of the facilities. But here comes the challenge. The challenge is the the mapping of the facilities, the Anganwadi centers and the villages. One Anganwadi center would be mapped to two villages, but the ASHA workers are essentially for a particular sector of population. The clientage is the same, but the numbers differ. So that's why the synergies between the two systems is more or less challenging at that level. So the work is in progress in addressing that issue as well. Besides that, ICDS, that is Integrated Child Development Scheme, which is there, is still a scheme. It has to be a program. I think it's a program now. So we have to see that how the digitalization of service delivery to the.
Sir, have you changed the slide because we are still on the
Uh,
first?
I have changed the slide.
We are
It's on
not
the
getting
second.
it. No, we are still on the
Let me
first
do it, sir.
main slide.
Yeah, I'll do it. Thank you.
So you are showing or I am showing it? I am stop.
I'll show
I am.
it, sir. I'll present it on the screen. Don't worry. I'm just moving to the second slide. You may please continue.
Actually, slide is not moving.
Yeah, just give us a minute. Preeti will share
Yes,
the
I
screen,
hope.
Dr. Gopal, and
Yes, I
then
hope
you
it's
can
visible to
continue.
everyone.
Not yet, Preeti. It's visible now.
Please go on
Thanks,
slideshow,
Preeti.
Preeti.
Yes, yes, it is visible.
Yeah.
Go ahead, Dr. Gopal. Sorry about this.
Dr. Gopal, please go ahead if you can hear us.
Has he dropped out? I don't see him.
Yeah, he doesn't seem to be on the call, so we can proceed.
I think so. Till the time he comes back, I'll just go back to Dr. Sujeet. Dr. Sujeet, even you had a presentation, right? Do you have anything to show till Dr.
Uh, s- Dr. Ranjan, sorry, if in case you're speaking, we aren't able to hear you.
Hello, are you able to hear me?
Yeah, Dr. Madan,
Dr.
thank you. I think you
Yes.
dropped out. We will put up the presentation again. We were waiting for. Yeah, I think you dropped. Go ahead, Preeti. Just to put up the presentation.
Yeah, it's visible. Thanks, Preeti.
Okay, go to the second slide when I was talking about the ICDS services. So see that key. I was talking about the ICDS reforms for digitalization and the service delivery through the common application software. We see that key how it can improve the service efficiency. Though there is overlap between the three, we talk about the convergence of ASHA, Anganwadi workers, and the ANM, but the clientage is the same. But whether the intended benefit of ICDS is reaching the intended beneficiary or not, that's another question which we have to ask. And we see that how the technology can bridge this gap and bring trust into the thing. Besides that, we are all pushing for Ayushman Bharat digital mission. Uh, uh, this is for integration of digital ID in this. We proudly say that we have been able to generate more than 70 crore of digital ID. But the challenge is embedding this ID into the patient health record so that they can be used and they can be interoperable along different systems. So I don't know how the things will evolve, but the systems are in place and we are moving in that direction. Besides that, the digital India for last mile connectivity and digital literacy among the frontline workers, that's a challenge. And in fact, we are doing a digital adoption study wherein we are trying to find out that what is the level of digital adoption in this. Digitalization is not that. We have to see that how adoption is there. I usually always quote about the Google, how the Google Maps and the Google thing, they have enabled the people build the capacities of using things. Look at the Facebook. They have not taught anybody about how to use and run the Facebook. You see that how people they have learned it themselves. We have to make a technology in such a way that it enables the people to use it properly. Collectively, these missions promote united data-driven citizen-centric nutrition experience is still work in progress, and we will be seeing more in the coming year. Preeti, next slide, please. The other aspect which we need to is we have to we have to strengthen the trust and capacity among the frontline workers. The trust goes when technology simplifies, not complicates. Right now, what we are saying, I've been always been a good proponent that we have to simplify things at the front end because these are the people who are not exposed to that kind of complicated nuances. We have to make their life simple. The moment simply things simplifies, things uptake is very high. You see that Poshan tracker, we trying to over 13 lakh Anganwadi centers now use Poshan tracker app. But I just cite an example from my experience of doing a self-assessment of IPHS
using the ODK toolkit. There are around 2 lakh facilities, and we have been able to do 99.6% of the facilities. Self-assessment has happened. The selling point of this kind of assessment was that the moment the facility does the self-assessment, immediately a report card is been given to the slide. The moment the facility submits its data, a report card ki where you stand, which are the weak areas, that kind of assessment report card is there. So if we want to have more uptake on this, we have to build in that kind of feature so that things can be simplified. Besides that, we have an integrated government online training program. I got is there. Modules are on maternal and child nutrition. Have enabled continuous skill. But you see that what is the uptake? Who are the people who are seeing? Even the adoption of this I got online modules, unless it is compulsory, people is not going to this. Besides that, we have been focusing, as our Honorable Prime Minister has always been saying, that we have to create a Jan Andolan for many of the things. There are many WhatsApp groups are there which enable the peer-to-peer digital learnings and other things. Then next please, next slide please. Then we have to see that how we can leverage the data and the digital platform real-time accountability. We now have dashboards that speak, telling us where children need attention, where the mothers are missed, and where our efforts are bearing fruit. We have to see that how this dashboard, we are having dashboard examples are Anemia Mukht Bharat, RCH portal, aspirational district program. These are many dashboard. I think when I was in Niti Aayog, we had a good partnership with the Pyramid Foundation, and seen that how the dashboard, the Champions of Change dashboard, which we could construct, that was used for monitoring and seeing a change in the aspirational district program. So we can these dashboards can facilitate data-driven decision making at the block level and the district level. They can help in the predictive analysis, identify high burden areas or timely intervention, encourages the performance-based reviews and resource optimization. These are the examples which are there. So we see that how we can have dashboard that speak telling us where the children need attention, where mothers are missed, and where our efforts are bearing fruit. Next, please. Beside that, beside having dashboard, we have to see that how the public, private, and the community partnership they are encouraged. Because we always stop here saying that it's a partnership. Partnership is not nothing. We have to all start calling this partnerships that partnership for public provisioning of services. We have to see that how this partnership become a mechanism for public provisioning of services, so that these collaborations, it can bring innovations, it can fund, and it can bring scale to the interventions which we are doing. Besides that, these public health systems, if we partner, because any small NGO-led or any small, even the donor-driven thing, they are all pilots. For giving it a scale, we require a public system engagement. If you bring a public system engagement, it can bring scale. Whereas the efficiency and the speed which the private sector bring in, we have to see that how we partner with them so that speed and efficiency can be brought into the system. The example is the Piramal Foundation. The Piramal Source was partnering with the Niti Aayog during the Aspirational District program. Had it not been a partner who brought in speed with the intervention, the scale to the aspiration block program would not have happened. That's an example, good example with that. So next slide, please. Now, the last is that what needs to be done. What needs to be done now? We do have a lot of data which is coming up, but we don't have a longitudinal data. A woman, we only see that cross-sectional data, how many women have been given AMC checkup, how many children have been underweight. But we don't follow because we registered that child in the system. Despite having digital tools, we have to follow that person till 5 years. The first 1,000 days, which Sujit ji was mentioning. We say that how we track, and so that at longitudinal level, every month we say that is there an improvement, is there a drop, how many children they have shown a drop in weight, how many children they have shown increase in weight, what are the other deficiencies in other things. Right now, we only have a cross-sectional data saying that so many underweight, so many people. You only talk about the service positioning part, but we have to focus on the outcome things which is there in that thing. Then we have to see that how we consolidate and integrate the data system to reduce this duplication. Because as I mentioned that Anganwadi digital tracker is there, where the HMI system, they are all having the data. of the same beneficiary. The child, how many immunization, the woman, how many pregnant women, what kind of thing. But once it comes to the comparison between two data, there's a lot of duplication because for the same beneficiary, you are having two entries. You have to see that how that duplication can be avoided. Apart from that, we have to build a multilingual digital tools. As I mentioned earlier, also the tools should be simple. At my level, at the national level, at my level, I can have complex operations, complex analysis, other things. But at the field field level, that means the woman who is fielding, she would be 10th pass, 12th pass, or less than that. He's not exposed to multiple digital tools. We have to make the front end very simple. The complicated operations can happen at this. Other thing is we have to build the capacities, digital capacities, and trust among frontline workers. It's not that the immediately, because what happens is if they are putting something, so they should not be punished. That means आपने गलत जानकारी भर दिया. We have to see that how we build the trust. That means if they fill it, they should know that what is the transfer. Immediately a result should be there so that the trust is built. That's another important thing going forward we have to do. Besides that, the partnerships which we are having, we see that how we create an institutional mechanism for that. These partnerships, we should call it as the partnerships for public provisioning. That means you all intend to have provisioning services to a single person or a single beneficiary. We see that how these partnerships are institutionalized. The mechanism is there so that it becomes a win-win and becomes a public good for all. And beside that, the use of technology, you should see that how the data which has been generated that is put to ethical use, and the what are the privacy concerns and other things that have been adhered to. So these are the things I think if we are able to do that, we would be able to leverage the technology and uh, see that how we can contribute to the nutrition in this. Besides, if we don't invest into the nutrition of the children now, the demographic dividend which we are now celebrating, more or less we
Absolutely.
land up with people who would be uh, underweight, whose BMI would be underweight, and apart from this underweight, there are other problems associated with that. Because undernutrition is now related to diabetes mellitus also as well, because of the shrinkage of your pancreas and other things. The next, please. The last one is that the future of the nutrition is digital, but its heart will always be human. The technology must empower our frontline workers and communities to make India truly uh, supportive. So that means Suposhit. You have to see that how we make a Suposhit this country. Otherwise, we would be only talking about this. If a child is malnourished, you see, we all, I've been talking in many of the forums. We see that we do have demographic dividend. Our age of the population, the age of the, we are the youngest population, age around 29 years of age. China is around 39 and the other countries, they are more than. But if you look at the nutrition aspect of our working population, particularly the informal workers who are there, many of them, they would be having BMI which are less than the recommended norms. If you are having a body mass index which is less, I'm just talking about the rough estimate. You see that how much work, how much productive these people would be there. That means the time has come that how we bridge this gap, how we bring in more trust, how we bring in more confidence among the frontline workers, how we make the partnerships as the partnership for public provisioning, and how we make it as a Jan Andolan and take the things forward. I stop here.
Yeah,
Thanks
yeah,
for
यहाँ पे
Thank you. Thank you, Dr. Gopal. That was amazing. And I
कितना
think
दूर है
that
यहाँ से
last
जो
line,
एड्रेस है?
uh, the future of nutrition is digital, but its heart will always be human. Technology must empower our frontline workers and communities to make India supportive. It's an amazing adage to go by and take it forth. With that, I'm going to turn back to Dr. Sujeet Ranjan. As consumers of the policy, what they make, we have to implement on the ground. What would be your takeaways from what Dr. Gopal has just mentioned, and as well as the discussion so far, in terms of the kind of collaboration that needs to happen on the policy front and also on the digital front, right? There need to be those alignments for policy, for scale, and then for impact and sustained impact on the ground. So I would just like to come to you with what are your thoughts.
Yeah. So thank you very much. And Dr. Madan has rightly explained, and that's the very learning things for most of us and what is happening. And I personally, I feel that by integrating technology with this nutrition program, which is the mandate, and Government of India, Niti Aayog, and the many organizations are supporting, like from my end, like from the Tata Trust, we're supporting a lot to the Niti Aayog as well as to the ministry, like how we are moving towards a more I can say transparent, efficient, and inclusive system. And technology, and the most important thing here, the mobile application, the SMS based awareness program, how that is spreading information about the balanced diet, the fortified diet, fortified food, the hygiene practices, to the families, those who are getting all kinds of services from Anganwadi centers. And I also feel like in coming days, lots of people are working, and we are also working like how to use the artificial intelligence and the data analyst, how that will help to identify the malnutrition hotspots. Because still, though from the aspirational districts, we have gone to the aspirational blocks, but even the blocks, how we can help, how the AI can identify the malnutrition hotspots, how we can design these targeted intervention in a more focused and manner, and so that we can reach out to the most needy population. And so I personally feel like this Digital India move for this in this field of nutrition is empowering the Anganwadi workers, the health professionals, and the civil society organizations like us. And but at the same time, the very important which is learning which I'm getting from the field, like the online, how the training to the our frontline workers, the grassroots level functionaries, as well as the e-learning tools and the real-time reporting system, how they can provide. And in coming days, I'm very much sure that the way things are going on, we will get the desired result in the coming days, and we can ensure that our services are reaching out to the most needy population, and we can see the change in the nutrition sector.
Thank you, Dr. Sujeet. I think that sort of completes the whole discussion as to how the government and the policy part look at it, and how the civil society and the implementation partners look at it. My next question, yes, Dr. Rajendra, we'll come back to questions later, so we'll come back. So my next question would be, in terms of way forward in terms of collaborations. Apart from the collaborations which already exist and the interaction and Niti Aayog does with different partners, takes it on its policy roles, what could be the possible collaborations, both from a policy, technology, implementation, and program perspective at the ground level? I mean, a lot of work is being done by Piramal Foundation right now at state levels, like I mentioned earlier, about addressing multidimensional poverty, not just in health, but also within the education space, and having a more holistic approach in addressing these issues. And nutrition then becomes a very underlying part of that, just like Dr. Gopal said some time ago. And he explained the different stages that if nutrition is not there, how it is, affecting the child and his or her growth in terms of their future. So I would just like to ask both you, Dr. Sujeet and Dr. Gopal, in terms of what are the potential collaborations which we have an opportunity to build in the future, but probably you don't see it right now, but that should be our way forward as partners, as collaborators towards the progress of the country. Either of you can go.
Yeah, I will request Dr. Madan to start, because he will share some of the perspective with Government of India and the Niti Aayog is.
Sure. Over to you, Dr. Gopal. Dr. Gopal, you're on mute. You may have to unmute yourself.
Yeah, can you repeat the question, please? Sorry for that.
Dr. Gopal, my question was, what is the way forward you see in terms of the collaboration that would be necessary for the next steps? Collaboration of technical partners, technology partners, ground level, implementers as
Okay,
well
got
as
it. Got
government.
it. Good. One of the important things when we talk about collaboration, we have to see that how we make the things win-win for both the parties. It can't be win for one and loss for the other person. Most of the collaboration nowadays, which are being pushed, is only on one side is winning, the other side is on the receiving end. We have to see that how we balance this kind of collaboration. That's one thing. When we talk about the technological solution, you name a problem and there is a solution for that. We have to see that how we cater to a need-based technological solution. That kind of thing we have to see the need-based. That means if I require that the data deduplication has to happen, are we having a technological partnership for doing the data deduplication of that? The government is struggling to with the data analytical parts. We have to find out areas where the government is weak and we can bridge in there and say that we usually will support in that space. We talk about the collaboration in the analytical part. That means data has been generated, help the system in doing the data cleaning, and then the data analytical part. We see that if you one of the challenges which we are having is to make the thing simple at the front end. For making simple at the front end, you have to provide a solution. That means uh, they say that they only collect the data, the ANM, Asha and Anganwadi worker. They don't know what is the status of the, what is the status of how in which direction the velocity of growth and other things are there. So we have to see that how make things easy. Previously they were having the road to health chart and other thing, and we have taken a lot of pains and efforts to train them and in understanding that. In the digital side also, if we are able to enable them, that would be another thing how we can build the trust of the worker, because digitally we are collecting it, but they don't have any records and other things to at least substantiate their findings and other thing. Unless and until we start trusting our workers, build their capacity to that extent that we have to invest into a lot of capacity building activities. We have to invest into the capacity building efforts of our frontline workers, see that how they are capacitated. And after their capacities are there, obviously the trust in utilization of the digital means would be improved. That means one is starting from the frontline worker. They are the cutting edge of our system. We have to invest into them and see that how their capacities are there, how their understanding improves, and how they start understanding the importance of data so that they give a good data to us so that we can plan and execute things and do mid-course corrections and the other aspects related to that. So that's one thing which we have to see that how we invest into that. Second thing is there are a lot of partners which are coming forward. Suppose you take the example, they only see that what the government is doing, they are only supporting that. Suppose I've seen many partnerships. They say that whatever the government is supposed to do, they're supposed to do suppose they are supposed to do 8, 10 activities. The activity is supposed to be done by ASHA and the ANM. The partner will come and only augment that activities, not bringing in anything which can improve the processes for implementing that activity. That means one of the other area as a way for collaboration is how you can re-engineer the processes so that it can have a more translational effect into the delivery of services. That's the important area. I think a lot of work can happen in that area. So apart from that, another thing is uh, do some research. We are lagging on. We wait for 2 years for the NFHS data to come, the NIN reports to come. Can't we have a system in immediately knowing that in which direction the person is going? Though there would be many claims saying that our data is coming, but where is the capacity for analyzing the data and taking the things forward? That's another area where a lot of effort would be required, a lot of support would be required, a lot of collaboration can happen in that area. So what is currently happening is that we are only doing whatever is doing. The high-end resource doing the work of a low-end resource. So you will have a good results, and as a result, the pilot would always be very happy to say that this thing we have been able to do. But we have to see that how a low-end resource which is deployed at this village level or Anganwadi center, utilizing your expertise, how you can improve that functioning and the delivery and outcomes from that low-end resource. That's a challenge. Otherwise, putting in high-end resources at a low-end place, which can be done by a low person. So that you see that how things we can do. I think if we invest into all these areas, the things will take it. No need to have a new thing. The only thing is we have to pause, see that which are the processes which can be re-engineered and how we can do things differently, how we can improve the effectiveness of these workers. But that kind of thinking we have to do. And here there is a lot of scope for doing research and other things. I stop here. Thank you. Pallav, you are
Thank you,
mute.
Dr. Gopal. Yeah, thank you, Dr. Gopal. That makes a lot of sense. And what I hear loud and clear is no need of re-engineering. What you need to do is effective allocation of resources and working bottom up in terms of the way we build these collaborations. Thank you. Dr. Sujeet, over to you. You're on mute, Doctor. Dr. Sujeet, you're on mute. You'll have to unmute yourself.
Sorry. So, from the civil society perspective, I'm I would like to suggest three important things which we are already we are trying to get more clarity here and how we can reach out to the our functionaries in a better manner. So, three important things. Number one is the capacity building and training. That's the one of the areas for the collaboration, like how to provide the e-learning modules and for the frontline workers and how they can understand better. And at the same time, it's not only the frontline workers, the local authorities, the leaders, those who are managing the program at block level, sector level, how they can understand better and they can take the right decision there. Second thing, I will how the monitoring and evaluation research. Dr. Madan has rightly talked about the research, the conducting research, the pilot studies. How both the things are very much needed for taking this digital India forward in the field of nutrition. And there is a scope for like pilot studies to test innovative approaches. Data-driven insights for continuous improvement. So these things are very important under the monitoring and evaluation. At the same time, I feel like we talked a lot about the nutrition specific things, but there are nutrition sensitives. So it's important to partnership and integration support, helping to integrate program of existing government program, those who are supporting nutrition, apart from the Poshan Abhiyaan, the other program with regard to Jal Shakti, then the program for the rural development, then the program for the local livelihood, how that can integrate with the digital India platform. So these three things, I think, are also apart from the initiative which government has already taken. We have to give more opportunity for collaboration in these three areas so that we can take the learning and take this result by using this digital India platform in a more professional and better manner.
Thank you, Dr. Sujeet. I think that sort of brings us to a conclusion in terms of way forward and moving forward. I'm getting a lot of Q&A requests from people, so I'm just going to go back to them until we close this in some time. Dr. Manisha, are you there? Dr. Manisha is a part of Piramal Foundation, works a lot with frontline workers. Actually, she handles one of the Center of Excellences under Digital Public Health. So, Manisha, if you wish to have any specific questions that you raised your hand.
Thank you so much, Pallav, and thank you, Sujit ji, and thank you, Dr. Madan. I really appreciate the way we're looking the way forward, and we understand the frontline workers are the cutting edge people, and we talk a lot about capacity building, the user research. But my question here is that, when we are saying so, how are we thinking about the nutrition status or the health status of the frontline workers per se? Is there anything the way we kind of, track or have any programs placed into this? Because I feel the frontline workers also come from the same community, and that can also be a value addition or a motivation factors. Would want to hear from any one of you your thoughts on this aspect. Yeah.
So I think this is a very important point you have raised, and charity begins at home. How if the Anganwadi workers and the ASHA workers, they are the role models for the nutrition program, and they are influencing all the pregnant lactating mothers, and they are like every day almost 80,000 Indian women give birth. So how they will be the role model. What they did and what they are suggesting to the families and influencing to the family for to adopt. So here the entire focus is like how we can build their capacity in such a manner so that they can play the role of a role model, how they understand first better, how they are very clear, so that they will be in a position to convince. The most important thing is the our it's not only just message, like the conviction. So conviction will also only come when I'm confident and yes, this will work well. This has proved. So that's the way we are trying to build the capacity of all the Anganwadi workers and the ASHA workers and also the helpers, because they are the almost 1.4 lakhs of the strength which we are having in the country, and they are the role models for that. So this is a very important point, and all the programs are trying to reaching out to them to for the conviction how they can have.
Thank you so much, Mr. Sujeet.
Yeah.
Dr. Rajendra Prasad, you had raised your hand some time ago, if you want to ask.
Thank you, sir. I would be talking in a different tone. Kindly take it in the most positive way. I have been in the field of public health for the last 50 years. I was working in the remote tribal area when the program of ICDS was launched in 1976. I have been coming into contact with the implementation of national or state level nutrition programs, not on a continual basis, but on a different touch and go like that, because I have been concentrating on other fields of public health also. But I have 3 relevant points here. So far, there has been excellent discussion, excellent presentation also, but I somehow feel the point has been missed. The title of the seminar was Nutrition at Last Mile. What has been discussed, whatever has been discussed, it is applicable for general strengthening, general gap filling, and general improvement or enhancement of the quality. But so far, I believe, correct me if I'm wrong, we have not touched the aspect of last mile part, which has got some special challenges, special problems for implementation and making inroads. That's one thing. Second thing is, so far, 75 years after independence and 50 years roughly after implementation of several programs, the nutritional indicators are not very encouraging and rosy. Still, the latest NFHS data show anemia prevalence is very high, more than 50%. Stunting, underweight, they are not reduced, they are rising. Later, in a figurative manner, stunting. And even after the processing and implementation of 14 lakhs ICDS centers, the purpose has not been fully served. And somehow I feel the management has been a little soft towards ICDS part, which is a crucial thing. So what I feel at this point is, we need not go for any special schemes, special programs. Everything has been thought out very, very meticulous way, has been grounded. But as has been elucidated by previous speakers, the implementation part at the grassroots level is lacking. So we have to focus on these things, particularly with the new weapon, newly acquired weapon of this digital process. So I would phrase it like this. We have to strengthen the program without introducing or thinking of any new schemes and new programs, as it is, wherever it is, and how it is. These things. And
noted, Dr. Prasad, is there any question that you would like to ask?
No, sir. No, sir. No, sir. Yeah. I just wanted to. I will take one more minute if I am permitted, sir. So I think
go ahead.
This is the thing, sir. So last mile, this thing also. See, my experience shows that for active and fully minded implementation of digital practices, the grassroots levels need to be upgraded in their competencies. They are very illiterate on this front. And first, a congenial atmosphere has to be created, receptivity has established, their basic fundamental competencies have to be raised, then only they will be coming forward to use it in an effective way. And we have to be very careful in trimming of the detailed part. From the inception of ICDS, I have been observing the pro forma for documentation have been very elaborate to the discomfort, and it has been a literal burden on the worker. That part has to be taken care of. So my recommendation finally is, now is the time to look at the implementation, not in a soft or firm way, but in a hard way. Something like an aggressive impetus is needed to strengthen the program with the newly acquired tool of digitalization, which to my mind has got specific application in supply chain management, documentation, and monitoring. Thank you.
Thank you, Dr. I don't know if Dr. Sujeet or Dr. Madan want to respond to any particular point, but yeah.
I want to respond thank you very much, sir, and you have raised a very valid concern. Just two things I wanted to convey. Like number one, based on our understanding, and you also rightly said that India has the right policies and programs in place to address malnutrition. We have created the necessary infrastructure, almost 1.4 million Anganwadi centers, a vast network of like the primary health care also. We are also having the budgetary allocation, though it's many analysis says that it's less than optimum, but utilization is also poor. But at the same time, based on our analysis, the two important things are coming. Number one is the poor implementation, like the implementation failure, how to reach out to the most needy, how on time and the same efficiency and the same effectiveness. That's the first thing, the implementation failure. And the second is the poor demand also at community level. Poor utilization of available services by intended beneficiaries. So how the nutrition is the coming as the priority, and how they can understand, yes, this is the program is for me, and the services which are meant for me, and I have to avail the services. So that part is also has to be strengthened, and that's why the role of government program like Poshan Abhiyaan is doing. But the specific as our program, the civil society organizations and the scientific, I think, program, how we can bring the community in the same discussion, how the nutrition is the good nutrition for all, can understand by the people very well. And the role of here the nutrition champions, nutrition volunteers, the civil society organization, the local self-help groups, the Gram Panchayat Samiti, the VHSND, all those people are playing an important role. And here we are hopeful that with the help of the integrated these efforts, we will see a change at that end. If the demand is there, the supply will also be strengthened. And I mentioned about the uninterrupted supply. That's the agenda. So there is a definitely, and one more thing I would like to say, the current behavior change strategy is also inadequate and needs improvement, the behavior change. Because that's the many organizations earlier were going with their own behavior change strategy, own behavior change plan. So that has also been taken care of in a very strategic manner. And I'm hopeful that the coordination with the other line departments, other line ministries, and the convergence will further strengthen based on this digital movement, and we'll see a different result in coming days. Yeah.
Thank you. I don't know who's sharing their screen, but we don't need this. Hello.
I think Pallav, we are done now. We can close it now. So I have to go for some other meeting.
We were to be there till 12:50. So
12:50. Yeah. I was told 12:30 only. So my other call is going on. So that's why. Okay. So if you permit, I can leave.
Okay, so we are our Q&A. There are a lot more people asking a lot of questions. So if you have another engagement, we can't stop you. But thank you for joining us and being there and answering. Yeah.
Okay, thank you.
I don't know who's sharing the screen. Can somebody stop sharing the screen?
No.
Yes, if someone from the meeting.
Yeah.
Yeah, now it's
Okay.
better.
Thank you. Sharad, you had a question as well.
Yeah, yeah. Hi, Dr.
Go ahead.
Sujeet. How are you?
Hello, very fine. Thank you very much.
We both worked together in care for a long time.
Yes, I know, I know. It's a
And
long association.
I'm right now in Bihar working with this PMGF project with Piramal Foundation.
Wonderful,
Uh,
wonderful.
so, as Dr. Gopal has already left and Sujeet, we already know each other very well. There is a
Very
question
well.
which keeps on coming to my mind for quite a long time because we have been seeing this change in overall systems for having better data at their level since last 2 decades. So from ICDS MIS, which was revised for first time around 2006 to 12. Also, we saw a change in whole health department's HMIS system, like RCH registers, HMIS, and Anemia Mukt Bharat dashboard, and all that. Most of these solutions, and even in ICDS from paper-based to Poshan tracker. So that way they have used technology in different ways from improving data sources at different levels from paper-based to technology. And this has been going on since long time. So they are trying to improve and many hackers are there. वो करेंगे उसको धीरे धीरे आगे भी होता रहेगा. They will try and collaborate and we will also innovate and provide some kind of good solution for that. At the same time, I feel the whole system is the way it has been designed, especially for digital solutions, are mostly system based. So it is for the system's requirement. From Anganwadi worker, she feeds in the data, it goes to their supervisors, to upper supervisors, till secretary level. And most of the data is mostly system based requirement के हिसाब से डिजाइन किया हुआ है. And these processes have flow. But we have missed a major angle where we see that we don't provide any solution for communities to actually have the ownership of this data, where they hold the
Correct.
data for
Very well.
themselves and they can take charge of their own health and nutrition aspect. As you said in your presentation also, that nutrition specific indicators require a lot of behavior change at family level, at household level. And this can't be only left alone to the frontline workers or to the system ownership only. So how
Correct.
can we make any digital solution to be more citizen centric, where they can take and how can we convince government to come up with that kind of flexibility to take that kind of digital solution for community level systemic change? So that was the only deliberation I had. Thank you, Pallav. Yeah, Dr.
Okay.
Sujit.
Yeah. Now this is you have like first of all, this is a very good point, and you have CARE has done a lot for this for the strengthening the platforms such as the Poshan Tracker, ICDS CAS, Integrated Child Development Service, Common Application Software, and how the digital database can help and monitor the growth and health of children and pregnant women effectively. So now we are having that we know that strength very well. We have communicated, and the policy leaders have also understood it very well that by integrating these things, we will definitely bring lots of transparency, the efficiency, and also the inclusive system. Now it's important, as I mentioned earlier, the three important things, how we can take care of the capacity of the functionaries as well as our local authorities. At the same time, how the partnership with the other line departments, how we can have it's not only just ICDS data, rather we can connect it with the nutrition specific, the line department, so that in a holistic manner, we can see that how the nutrition services, those who are directly or indirectly leading towards a good nutrition, reaching out to the community as well as the getting the desired result. Because like if you are providing the food, good food through the supplementary nutrition program, take home ration, but at the same time, if the sanitation is an issue, the our water is an issue, then your status is an issue. It's not possible to get the desired results. So such things are very important when we are going to collaborate to support the vision of the healthy and nourished Viksit Bharat under this current phase when the digital Bharat is taking this thing forward. So lots of advocacy is very much needed here, and lots of efforts from the civil society organization, from the technical organizations are needed. How to get all those things at grassroots level, at the like the local functionaries level, so that they can understand and they can enable, that will enable the government and also the organizations to collect the real-time data, the monitor the data well, monitor nutritional data as well as the nutritional sensitive data as well, and ensure that services reach the most needy and the remote communities. So lots of efforts are going on. Niti Aayog is also working, and Piramal's foundation is also working in this direction. So I'm hopeful that together we can make a difference in coming days. Yeah.
Thank you. We have time for just one more question. So Anurag, it's over to you.
Thank you. Good afternoon, Sujeet sir and Smith sir. Actually, I wanted to ask this. Saratji has already mentioned that behavior change, and you have also discussed about the behavior part. I have one or two questions on that, especially like how technology can do for what technology can do for intra-household food issues or food dilution type of things. And you have already, and how technology can ensure the iron intake or IFA intake at beneficiary level. So yes, sir, you remember in NHP we have worked on self-monitoring tool kind of things.
Yes.
And how we can develop that kind of technology so that beneficiary can monitor their own services at family level. We can think on those things also, because malnutrition comes from individuals, and our whole discussions and things focused on system, digitalization, system, data monitoring, dashboard, and capacity building of frontline workers. So I have these 2 points: intra-household food insecurities and sanitation and all these issues. How technology can address with these things? Yes, sir. It's a small thing.
Yeah, I think I fully remember the individual tracking model. That was the one of the best practices. Niti Aayog also adopted the same, but now the technology is there. I feel that now everyone is having the smartphone, and the efforts are there that the mobile application and the SMS based awareness program, how that will spread the information about the balanced diet, the our immunizations, then the essential nutrition, essential behaviors, how that will communicate through a very proper manner, proper channel, and the hygiene practices also to all the pregnant lactating mothers, and how the family can understand it. Here, the male engagement is also very important. So the efforts was also there, like the mobile number, how we can have the male members also of the mother, and we can provide that information directly to the pregnant lactating mothers as well as the family members, and in their local language, so that they can understand, and that will be that will also be reinforced by the counseling session made by the our Anganwadi workers and ASHA. So that will further strengthen. Apart from that, when I was with Piramal Foundation, like our efforts was there for the remote advisory health services, the outbound calls, how we can, if we are having the number, how we can reach out all the pregnant lactating mothers from the center, and we can discuss about the food system, about the food practices, about the hygiene practices, about the immunization, about their TT vaccine, about the IFA tablets, what are the issues are coming, how the same can be communicated to the ASHA workers if there is any issue, so that the immediate action can be taken by the service provider. So that initiative was also initiated, and Government of India has also taken that learning in a very positive manner. I think such efforts are going already. That's why I'm saying all those things are there. It's going on, but the efforts is very much needed so that we can reach out to the large population. India is a big country, so how we can reach out to the large population in a more systematic and manner. And here the support from the government is very much needed, and also from the role of civil society is very much important, so that we can ensure that the such things are being accepted by the community in a very proper manner and the desired manner. So opportunities are there. Things have also been established. Things are also been proved that yes, that will work well. That is working well, and we are having the some kind of evidences that that has worked well from the care days to this current digital India days, and I think that will work very well. Otherwise, I mentioned about the behavior change communication. Many organizations were used to come earlier with different kind of strategy. Now we want very clear that there should be one message so that there will not be any kind of duplication, and there should not be any kind of confusion at the household level, at the mother's level. So efforts are there and already going on, and you people are there. How together we can reach out to all the mothers, how we can see that they are getting the right message on the right time.
Although I said this was the last question, Nirmala, I can't deny you a question considering your work in this area for so long. So can you please make it a little quick so that we can end on?
Yeah. Hello, Dr. Sujeet, and it's after a long time, like connecting with you after that coalition we were also part of when I was working on the nutrition programs. So actually, the question was for Dr. Gopal, but he has already left it. It's more related to policy that, nutrition is not of one department. It is across several departments. And now, since like 1 hour, we are discussing about digital transformation, digital tools, learning, giving to the FLWs, and ultimately everything gets bottled down to the frontline workers. So, like my concern is first how to create a convergence on ground, and obviously to create a application where like already like Dr. Gopal has mentioned that it should be very simple and easy to manage by, because we know our frontline workers, they have a limited literacy and those competencies. So what could be the solutions? Basically, just wanted to listen from you, because this is a very challenging, humongous task for the country.
Yeah. So this is a very relevant questions, valid questions, and the coordination. Since beginning, we are talking about the coordination, how the coordination, the convergence. Coordination of the line department, convergence at field level, convergence at block, district, state level. But the most important convergence, I personally, based on my learning of more than 2 decades, the most important convergence is at grassroots level, like how the Anganwadi workers, ASHA workers, and the ANMs, and the SHG also. How that convergence is very, very important, so that we can somebody who is there and for the pregnant lactating mothers and the children, because hardly a mother is getting an opportunity to interact with the service providers once in a month or so. So that convergence is very much needed. But and the overall, I'm saying, when we like in the year 2014, when under the leadership of Professor M.S. Swaminathan, the leadership agenda was published, discussed, and presented to the Prime Minister. Then the Prime Minister, and the Poshan Abhiyaan was finally launched in the year 2018. like in the year 2021, again under the leadership of Professor M.S. Swaminathan, we came together and we decided to go for commitment to action. So call to action was there earlier. Now it's a commitment to action, and commitment to action was the most important thing. Was commitment to action was the institutionalized leadership for nutrition within at the leadership level, like the from the and the at state and district level and the block and field level. And that's why the portion of our aspirational districts, how the district my state is going to be the head of the district, and he is taking the nutrition as a kind of in a mission mode, and he or she will be responsible to take this in a very planned manner. And the high level commitment of leadership initiative, the evidence-based framework, the specific financing, the convergent action plan with the line departments, and the data efforts also. So that was there, but and now the aspirational blocks is there also there. How the this convergent is there, we see a kind of in a vibrant manner at block level. So that is there. And recently, if you remember, the coalition decided to go for the district action plan in Assam, Jharkhand, Chhattisgarh, Madhya Pradesh, Odisha. So that was again the efforts was how we can have the common plan for all the four line departments, those who are directly related with the malnutrition program, and accordingly they can go for the budget provision, and they can go for their functionaries in communication in such a manner so that the action will be taken at the grassroots level. So efforts are going on, and here again I will like to mention the role of civil society organization is also very important. How they can play a kind of catalyst role to bring these key functionaries at one platform at village level as well as at block and district level, because state is though that's the policy decisions, but most of the active activities are taking place from the district and field, and the kind of efforts are going on under the block aspirational program. I think I'm very much confident that will bring a new model for convergent, and that will be a kind of role model for many other states, many other districts, and other blocks also. So I'm hopeful that the block aspirational districts or block aspirational plan will be a kind of new way forward in this nutrition program to bring the nutrition sensitive and nutrition specific together.
Thank you.
Thank you, madam.
We've run out of time. I think that was a great discussion, and thank you for all those questions and for that interactive dialogue. I'm going to ask Ishmeet Singh, our CEO of Digital Bharat Collaborator, to come in and just give his reflections and thoughts, followed by Ravi, our Chief Technology Officer, who will give in his vote of thanks to him. Over to you, Ish.
Thanks. Thank you very much, Dr. Sujeet and Dr. Gopal for the discussion. I think it was a great discussion. In my opinion, I think the big highlights for me was not only the fact that both of you talked a lot about collaboration and coordination between departments, but also the role of civil society and development partners like us. I think that's very, very heartening to hear about it from in terms of how we can support and work with the state governments and the department, central ministry as well, to support in these initiatives. And for me, in my experience of the last 5 years in the sector, I think the fact that while technology can be a great enabler to build accountability and efficiency, and I think a lot of effort is being put by the ministry, by the departments, by the state, by the development partners in this regard. I think the big area which we need to all now start focusing also is to start using the data to effectively drive governance. And I think you've all mentioned about the fact that how we have got some great tools, but how are those tools really helping the specific health actor to be able to drive better decisions and to support either service delivery or the nutrition challenges, etc. I think that's really the time where we have to focus on. Like Dr. Gopal talked about the Poshan tracker and how the entire Poshan Abhiyaan program is really building a strong pipeline of activities to support the nutrition exercise in the grassroots level. I think if we can really build in a strong governance and supportive supervision to enhance the delivery of those programs, I think that will really go a long way. Thank you very much once again for your participation to everybody here, as well as Dr. Sujeet and Dr. Gopal. And I hope we can continue to have such forums to have these discussions forward. Thank you very much. Thank you.
Thank you very much. Thank you.
So I'll be quick. Thanks so much. I was going to say my quick takeaway was improving the processes of government with better data sets. And I like the tagline, the future of nutrition is digital, but its heart is human. So with that, I will say thank you, everyone. Specifically, I guess our team, Piramal Foundation, Avian WE, also the esteemed speakers, Dr. Sujeet Ranjan, Dr. Gopal, and all of you who actually very enthusiastically participated and had a lot of questions that we weren't able to even get all of them. But we hope to have more such webinars, and those of you who have signed up, we'll keep you informed when we have such webinars. Thank you, everyone, and look forward to another discussion sometime soon. Thank you.
Thank you very much, Mr. Ravi, and thank you very much to everyone.